Hi everyone, my name is Othman Al-Sawaf. I'm a physician at the German CL study group, and I'm going to discuss the question on how can we use minimal residual disease to guide treatment decisions in the management of chronic lymphocytic leukemia. So when we consider this question, we first need to check what kind of MRD assessments are available to us. On the one hand, we can measure minimal residual disease for CLL in the peripheral blood, which is the most conventional and most widely used way, or we can test MRD in the bone marrow. Each of those approaches has certain advantages or disadvantages, but generally they allow us to understand how well a patient responded to treatment, or how well is the patient currently responding to a treatment if the patient is still receiving therapy. And then the other question is, what kind of methods do we use in the sense of whether do we use flow cytometry, do we use ASO-PCR, or do we use next generation sequencing in order to measure the load of malignant cells in a patient? And again, here the most widely used method is probably the flow cytometry, given that it is widely available for hematologists around the world. And it allows us to usually detect, depending on how many colors you apply, you can detect up to 10 to the minus 4, even, or sometimes even, for instance, with 10 color flow cytometry, up to 10 to the minus 5 in terms of sensitivity. And with NGS, which is not widely available and still relatively expensive and laborsome, you can achieve levels up to 10 to the minus 6, which still has a lot of prognostic meaning, getting into these deep MRD levels. So when we consider now, if we have any of these MRD approaches available, if we think now, when can we, outside of clinical studies, use MRD assessments, then we really get into a more or less data-free zone in terms of, can we really improve outcomes by using minimal residual disease in order to guide treatment duration or treatment intensity? And I think this still has to be shown that we can really improve outcomes by applying MRD outside of clinical studies. But I think in general, it is worthwhile using it to prognosticate. So if you have a patient who has received 12 cycles of, say, venetoclax-based regimen, and you want to understand whether the patient has responded to treatment in order to tell the patient, was the treatment successful, or when can we expect a relapse? And for that, minimal residual disease is very useful, because a patient who has still detectable MRD at the end of treatment, while mostly there is no treatment reimbursed for going beyond 12 cycles, we can still tell the patient that a relapse within the next 2 or 3 years is very likely, although this doesn't mean that the relapse necessarily has to be treated. But I think in that sense, MRD is very valuable as a prognostic parameter. And we've previously applied various tools and methods in order to demonstrate how we can integrate minimal residual disease in our prognostication. And one approach for this might be, for instance, the CIRI, the continuous individualized risk index, which allows us to harness this kind of knowledge that we gain during and after treatment. And then there are certain individual cases where MRD can guide treatment decision or guide treatment duration. Already in the era of chemomonotherapy, we observed that patients who, after 3 cycles of FCR, for instance, have a similar outcome to patients who have received 6 cycles of FCR if they achieved undetectable MRD levels halfway through the treatment. And this can be very useful in a patient, for instance, that has a lot of toxicity while being on therapy, and where you're not sure whether the patient could, with supportive care, continue treatment, or whether the patient should discontinue treatment. And if you do an MRD assessment in this out of clinical trial setting halfway through the treatment, and do see that the patient has no detectable MRD anymore, you can discuss this with the patient and tell the patient that there is not necessarily required to continue the therapy, but that the treatment can be discontinued due to toxicity with a at least relative certainty that there is already a good remission. So in these kind of individual cases, MRD can be quite useful in order to guide the treatment intensification and duration. And I think in the next step, we need to see, because we've seen really a large battery of different phase 2 studies that are exploring ways to guide treatment duration by measuring MRD, by measuring time until MRD negativity is achieved and with different methods and at different time points in different compartments. But I think what we have to see now and in the near future are really randomized studies that prove that MRD-guided therapy has a benefit over what is now conventionally used as a fixed duration treatment at the front end and relapse setting. So I think this will be probably the next big question that we need to answer in the field of CLL. And I think for that, we will need to run further clinical studies with randomized arms in order to answer the question of how to definitely apply MRD guidance in routine clinical care. Thank you very much.